Hey, hey. So this is going to be chapter 5. Turn this down. Chapter 5 is super short. Let me save and share my screen here. So as I said before, chapter 5 is on confusion, dementia, and move this down. Alzheimer's. Just out of the way. All right, and I'll pull myself down here. Okay, perfect. All right, so I'm all set up. So this is chapter 5, and let's get started. Confusion is the inability to think logically and clearly. Anybody can be confused, okay? When was the last time you ate? When's the last time you went to and slept? When you don't understand something, you have confusion. Delirium is a state of severe confusion that occurs suddenly and is usually temporary. So anybody can be confused. Anybody can be delirious or have a state of delirium. Okay. Um, this comes into play a little bit later, especially with our elderly people. All right, so how do you feel when you are confused? It interferes with the ability to make decisions. You might have a personality change, might get angry, have depression, irritable. Could be permanent or it could just be temporary. So if y'all were here, then I would ask you what could cause confusion. The number one thing for confusion in our elderly people are urinary tract infections, UTIs. After we clear up that UTI, they're not confused anymore. Okay. Other things, head trauma, low blood sugar, dehydration, fever, just like things that happen to everybody, but UTI is a big one, especially with our elderly, because they don't feel those, don't have those senses until it's too late that they have UTI. Okay. All right. So how do you deal with a person with confusion? You don't leave them alone. You want to stay calm, have a quiet environment so other distractions won't be able to come in and make them more angry. Explain what you're doing with simple instructions. Be patient. Don't rush the resident. Talk about the plans for the day and keep the routine. Of course, you're going to promote self-care and independence. Never leave cleaning agents around because they might think it's something to drink. And then observe any changes and tell the nurse about them. Okay. All right. Causes for delirium, infections, disease, fluid imbalance, poor nutrition, drugs, and alcohol. Okay. And then delirium is a severe case of confusion. So it'll just be heightened agitation, depression, irritability, changes in consciousness, short-term memory loss. Okay, just remember, it helps to be gentle and keep one's voice low when communicating with someone who is confused and disoriented. Low really just means don't yell at them. Use the person's name and speak clearly using simple sentences. Reduce distractions as much as possible. All right, so here are some key terms. Turn in your book. This is chapter 5. So turn in your book to page 116. And the key terms are here. We have cognition, which is the ability to think logically and clearly, which is the opposite of confusion. Cognitive impairment, you can't think logically or clearly. You have lost that ability. Dementia is a serious loss of mental abilities thinking, remembering, reasoning, and communicating. And then Alzheimer's is a part or up under the dementia. Okay. Dementia is not a part of normal aging. What is dementia again? A serious loss of mental abilities, thinking, remembering, reasoning, and communicating. Following are common causes of dementia: Alzheimer's, um, multi-infarct, which is kind of like a stroke, Lewy body disease, Parkinson's disease, and Huntington's disease, which are all nervous system diseases. And what's a part of your nervous system? Your brain. How do you diagnose dementia? It's very complicated. They're going to have to look at their medical history. They're going to do a physical. They're going to run some blood tests and maybe do a scan of their brain. They're going to look at different activity waves using the brain. It's called an EEG. And then they're going to rule out what they don't have and then kind of guess on what they do have. It's really hard to diagnose dementia. Okay. Some fun facts here. I like to pull out that the length of time, which is at the bottom, length of time from onset to death can range from 4 to 20 years. And this is for Alzheimer's. Okay. 1 in 10 people age 65 or older has it. African Americans are about 2 times more likely to get Alzheimer's as whites, while Hispanics are 1.5 times as likely. Risk increases with age, but is still not a normal part of aging. Okay. Alzheimer's is progressive, it is degenerative, and it is irreversible. You can slow it down, but you can't stop it if you had it. It's going to look different for everyone. What we can do as CNAs, we can encourage self-care and keep them as active as we can physically and using their minds. Puzzles are good, coloring is good, music is good, all of that. Okay. Don't take anything personally. If they are going through that anger stage, then they're going to be angry and it's going to be pointed towards whoever they're around. That might be you. Okay. So page 118, this is perseveration, the repetition of words, phrases, questions, and actions. You might have some people that will say the same thing over and over again. Time to eat, time to eat, time to eat, even though they just ate. Time to eat, time to eat. Okay. They might have those repetitive phrases or actions. What we're doing with people AD is Alzheimer's disease. We're approaching them from the front. We're smiling. We're looking happy. We're not looking like they're causing a problem already. We're going to talk to them, identify ourselves. We're going to speak slowly using a lower tone voice so they can hear us. We're going to cut all noises in the background so it won't be a distraction. Don't be offended if you have to repeat yourself. And then you might have to use different techniques like books or some pictures that you're going to point out. This is what we're going to do now first. This is what we're going to do next. The other thing is using lists because they need to have a schedule. Schedules are really good for them. They know at 9 o'clock, they're getting up and eating breakfast. At 10 o'clock, it is craft times. At 11 o'clock, you're going to be changed. At 12 o'clock, it is lunch. So if that is a checklist and it is on their door or on their wall, it's really good to have that schedule and they can refer back to it. Okay. All right. If a resident forgets or shows memory loss, just repeat yourself. Repeat yourself, let them know who you are, what you're doing. You cannot get tired of it, and then keep it simple. Okay. If you need to break things down, break different tasks down, that's okay. It might be as simple as getting dressed in the morning. You might have to break those down. Um, while they still can put their clothes on. All right, first step is we're gonna put this shirt on. You like this shirt? Okay, let's put this shirt on. You're waiting. Next, you're putting your pants on. Here you go. All right, so you might have to be a little bit patient with them. If a resident has trouble finding words or names, suggest the word that sounds correct. Do not try to correct the resident who uses an incorrect word, but just, if they say time and it's really clock, then like, oh, the clock. Okay, yeah, yeah. Um, instead of no, it's not time, it's clock. So just show them respect, as you would any of your elderly patients or loved ones. If they can't say something, encourage them to point. If there is like a pictures, you can use your pictures or gesture to act out. Always keep the activities simple. Of course, you're going to redirect if they're trying to do something unsafe or not allowed. Limited times you say don't, just do redirection instead. The resident hallucinates or is paranoid, don't take it personally, try to redirect behavior or ignore it. Okay. If a resident is depressed or lonely, give them some one-on-one time, involve them in activities. You can see this really happening in um, long-term care facilities like nursing homes. They used to come out, they used to be involved with the different activities of the day. Now they just stay in the bed all day. Try to get them up, try to get them out of their room, even if it's just to sit in the at the door or in the hallway or something. Try to, instead of them eating in their room, have them eating in the dining room. Have them socialize a little bit more. Okay, let's see. Bathing, we already talked about bathing because we already did it. Okay. So sundowning. Sundowning is when something happens, basically when the sun goes down. So it could happen in the late afternoon or evening. If you notice every day at 6:30, your patient gets up out of they've been fine all day. Then all of a sudden they get up out of bed, they're confused, they're trying to leave the building, but it's always every day at 6:30. Then they have sundowners. Okay. What do you do with that? If you know every day at 6:30 they're going to do that, then you prepare before. You ask the nurse if they can get some medicine, or you go and set them up with an activity or something before 6:30. You try to get them involved in something so you can redirect them. And then at 6:30, their mind is too involved in other things that they kind of skipped over that sundowner syndrome. Catastrophic reaction, that's reacting to something that is unreasonable, exaggerated. And then pacing, you just see the people walking back and forth, back and forth, back and forth. Wandering, wandering is where you have residents that are walking and they have nowhere to go. They're just walking aimlessly. They could be walking around the building, they could be walking around outside the building. Wandering in Alzheimer's is really, really dangerous because if they elope and they get outside of the building, then they could probably not remember where they came from, how to get back home. And then you see on the news where they have the cold silvers where an elderly person has vanished and then they find them a couple of days later, um, expired somewhere. So that's why you have your people that have confusion, chronic confusion, or Alzheimer's or dementia locked behind closed doors like memory care. So they can't elope. If you have your normal residents, they it's not called eloping if they don't have confusion. They're just leaving for the day and then they'll come back at nighttime, or they're going to the grocery store and then they're coming back. You know those residents, but they're not confused. They actually know where they're going, what they're doing. They have a plan. Okay. Hallucinations, oh, those are false and distorted sensory perceptions, which are different from delusions, which are persistent false beliefs. So a delusion could be they're trying to kill me. They're trying to kill me. Somebody's trying to kill me. I don't want to eat all of this food. A hallucination is I have spiders on me, or it's a sensory. So I see something, I feel something crawling on me. I see there's a man in the bathroom right now, and he's staring at me. Okay. So that's the difference between hallucinations and delusions. And if you look on page 124 in the book, that is where you have those two definitions. Okay. All right, rummaging. People that rummage through drawers, they're just opening up the drawer and they're just going through it. It could be your drawer, it could be somebody else's drawer. They're just trying to find something. And then hoarding, you see people that are just collectors. They collect everything. They don't throw anything away. And if you try to throw it away, then they get super defensive. I always think about that show, Hoarders, which is very difficult to watch. Okay. I am going to skip over this, but you have all of these in your book, definitions in your book. Residents with Alzheimer's may try to elope or leave the facility unsupervised and unnoticed. If a resident with Alzheimer's disease elopes with a nursing assistant, the nursing assistant must inform the nurse right away. The earlier the search is begun, the more likely the resident is to be found safe and nearby. Okay, very dangerous situations. People with Alzheimer's may be at risk for abuse. One reason for this is that caring for someone with Alzheimer's is very demanding physically and psychologically. So this is like the caregivers, and this is also you. Nursing assistants should take care of themselves to ensure that they are able to provide the best possible care. So take care of yourself, reduce that stress. Don't take it out on your residents. Okay. All right. So we are now on page 126, which is awesome. I told you this is a short chapter. Okay. So creative therapies for residents with Alzheimer's disease, validating, okay, giving value to or approving. And these are things that you can do. You have the first one is validation therapy, allows residents to believe they live in the past or in imaginary circumstances. So you can say, they can say, you'll ask, what year is it? They'll say, oh, it's 1952. So and so is president, and my wife is on the way. All right. If they're happy in that, they live in there, they're not combative, it's not making them sad or depressed, let them live in that validation therapy. Let them live there. Okay, there's nothing wrong with that. Remember, remembrance therapy, that is where you guys are talking about the past. How long were you married? How many kids did you have? When you were younger, what kind of cereal did you eat? That also helps them to bring up old, long term memories. And also, they're exercising their brain and they're having a conversation with you. So they're being very social. Activity therapy uses activities that the resident enjoys to prevent boredom and frustration and to promote self-esteem. This is why you have um, arts and crafts and music and the dogs or the pet therapy, because they need something to still be active and doing the things that they need to do to instead of just laying in the bed and not doing anything. Hey, music therapy is the last one, and we all love music. I don't know if you don't love music, please tell me why, because we all love it. Okay, and that is it. Good job, guys. Do good on your tests or on your quiz. I mean.